So I'll be talking about this hyperlipidemia on following topics for the next 25 minutes. So this is the slide actually I, as a medical student, most hated because most of the time this was in the papers and we had to write the these all these algorithms and explain how these statin work. And so we had to remember everything for the the exam. I think the medical student might witness that you must have recently gone through this hard period, but it still, yeah, now it is worth to know little actually where does these drug work. So other than that, there's no point. Okay, so this cartoon shows the importance of the types of cholesterol and triglycerides. So here you can see the HDL, right? So and LDL. So LDL also, and this category, the cholesterol has a new or other substance called LPA, and also triglyceride. So it comes in intermediate density and very low density and chylomicrons. So when you consider these lipids, so HDL is anti-atherogenic, and others are, other than the chylomicrons, are atherogenic lipoproteins. Okay, so and if you carefully see this, and in addition to this lipoprotein, you see this protein component. Most of the time, this component is ApoB100. So most of these atherogenic cholesterol consist of ApoB100. So that is the latest actually the treatment, or I would say monitoring of these lipid patients. And ApoB48 also a part of chylomicrons and remnants, and HDL will have ApoA1. So these ApoB100 assessment is available. If you want to get it done, it is available in the private sector. So this is actually a very old formula which was used to calculate the cholesterol, basically lipids, in traditional way. Nowadays, most of these assessments are done in directly, so hardly these measurements are used in modern labs. But still, most of the labs in normal or traditional way, they do practice this. So this is again common slide. I'm not going to talk too much, and it is again third year pathology lecture. Okay, so this very interesting slide, I would say. So with the revolution, human evolution, so we can see this LDL has drastically gone up. So humans at present, they have very high LDL compared to their ancestors. All other mammalians, so they have LDL cholesterol, but they are very low levels. But humans, they have very high level of LDL cholesterol compared to the other counterparts. So not only that, with the age, and this cholesterol also rises. So you can see this with the age, even this second decade, it starts rising. Not only that, as a result, these cholesterol deposits also increase from the fatty streak to well-blown cholesterol deposit with even calcification. So that happens with aging. And some disease like familial hypercholesterolemia and polyhypercholesterolemia conditions, they will have even early onset of these peaks, and they will have this progression very early in their life. So it's very essential the people with these conditions need early attention and treatment. So this is actually almost all trials which were done in cholesterol lowering. So both primary and secondary prevention, if you plot them, so you can identify LDL is the main cause for the atherosclerosis. So if they have very high values, they will have very high atherosclerosis or the ASCVD risk. So almost every trial, if you mention, so that will be included in this graph. And also the regression of cholesterol, if you regress LDL, yes, that is also proven. And the initial trial done with the pravastatin, which is not currently used now, and atorvastatin compared at early 90s. That time also there was a significant the cholesterol burden or cholesterol plaque reduction compared to the pravastatin. That was the first time they showed the cholesterol lowering effect in the reduction of coronary plaques. And latest, actually, the newer trial shows very significant reduction in cholesterol plaque deposits when you have very low values of LDL. And so I'm going to discuss a case. Actually, this was some time back. This lady with diabetes and who had a TIA or stroke some time back. And she was on atorvastatin and aspirin. She presented with inferior MI and she underwent successful primary PCI with drug-eluting stent, and she was started on atorvastatin. She comes in 2 months with this lipid profile. So she was a bit concerned about this cholesterol because all the labs says these are low. And actually this patient was instructed to stop cholesterol lowering tablet by the lab. So they said to stop because your cholesterol are low. And indeed, is it low? No. Actually, still they are not under control. So why I say? Because if you have this very high coronary and the TIA or the cerebrovascular events, you have to keep the cholesterol levels are very low. So they are under new guideline. They say you have to keep LDL well below 40. So what is your action? What do you do? Stop atorvastatin? No. Reduce dose? No. Continue? Yes, you continue it. Or you add acetaminophen. You may add a small dose and you can try. Now you don't need to wait till your report comes. Even if you suspect the patient is not controlled with this atorvastatin, you can straight away add acetaminophen. Okay, so this is the place where the new guideline comes. So if your patient is in the extreme risk group, you have to keep the LDL well below 40. And depending on these risk factors, you have to give them a goal of their LDL levels. So these the guidelines say if you have very high risk, you have to keep less than 40. Okay. The patient with high risk, you may control it at 70. The patient with very high risk, 55. The patient with even primary prevention, you have to keep it well below 55. They have very high risk, or if they have very high family history. So how do you risk stratify your patient? Okay, so this purpose, there are risk scores, easy to use, and most of the things are actually the European-based ones. So this is ESC risk stratification score, and the second one is Framingham, and the third one is WHO. The special thing about this WHO, they have special edition for the Southeast population, including Sri Lanka and India. So they have the risk calculator. We can use it for our patient. And it is very interesting and easy to use the risk calculation. And the only difference is their cutoffs are slightly different from our ones. Because Southeast Asians, I will talk to later regarding this LDL reduction. But if you want to use these risk calculators for your patients when they come to you, and that is again practicable. And they will give almost similar or more closer LDL target values. So there are ESC also comes in act and very easy to install, and you can use these score depending on your patient. So if the patient is less than 70, these are primary prevention. If the patient has diabetes, if the patient has already cardiovascular problem, then you have to use this one. If the patient is having other one with other very high risk special CKD patients, you can use the other risk. So then you will get the 10-year risk score. So depending on this risk score, you can start the treatment. So this is what you get in those calculations. So then you decide which group is in your patient, right? So very high risk, moderate risk, or extreme risk. So again, try to enhance risk score. So nowadays it's not much use, but you can use it. Okay. So I'm not going to talk about these patient who belongs to very high risk group, because if you go through all these guidelines, you can see. But basically, if you have documented cardiovascular event, so those patients will belong to this very high risk group. Most of your day-to-day practice patient with recent coronary events, so they will come as a very high risk group. In addition, the patient with diabetes, with target organ damage, they will also belong to this group. Okay. So this cartoon summarizes the all these groups. So, and depending on their risk scores. So whatever the risk group, you have to keep the cholesterol depending on their risk score. So if the very high risk, yes, 55, extreme 40, and 70, 100, and 120 or 160. So again, after this risk assessment, you can put your whole patient in these 4 areas depending on the risk. So as a result, then you can manage easily the OLA step line, or you can do the cholesterol lowering depending on their risk assessment. Okay, so what is better? Is that the lowest cholesterol better? Yes. Again, I showed that relationship with the cholesterol lowering with the PLA, and also this all trials again. If you put this primary prevention trial again, Jupiter, WSP trial, and also the secondary prevention trials, the lower the cholesterol, the better the outcome. Okay, so this is very clear beyond a doubt, and most of the trials have shown without any hesitation. And what is the safest? So, and actually there's no low level. So the lower level is the best. And if you can achieve the lowest, so that is supposed to be the best. And okay, so this is again, if you reduce this LDL cholesterol well below the target, then they will get more cardiovascular benefits. And this is again the all trials which have been published recently. So so they showed the lower the cholesterol, the better the outcome. Okay, so these are the actual recent trial, IMPROVE-IT and Fourier trials. I'm not going to talk much, but the last 2 trials, they use basically these especially these Odyssey trial, alicromide, and the Fourier trials also they use ivermectin. So they showed very much better outcome than the traditional trials with very low LDL cholesterol. And this is again the summary of these trials. And so from take home from these LDL, so LDL level increases with age. LDL is the main cause for the atherosclerosis. So regression of atherosclerosis plaque is possible with adequate lipid lowering. So that is proven beyond doubt. And latest guidelines have definite treatment goals for all of your patient categories. And risk scoring system help to risk stratify your patient. So then the management will be easy. So there's no, there's unclear areas. You can put all your patient into these categories and they will have definite goals of cholesterol lowering. So lowering of LDL cholesterol is safe beyond the doubt. Okay, so then how should I or how do I treat my patient? So once you diagnose this, once you set up a goal, again, it is very essential as this treatment. The initial part is with this lifestyle measures and healthy food habits. You have to instruct your patient regarding this. This is again very important. But ultimately, this lifestyle modification and these food habits will reduce the patient's cholesterol by 15 to 20% of the baseline. Okay, so you can't achieve beyond that. So, but that will be again important for the management of your target LDL. Again, these things are there, but I'm not going to talk because the previous speaker also talked similar to this. And so these are actually the recommended pharmacological treatment goals for the primary preventions. So, and the recommended, the even primary prevention, you have to use the high intensity statins. Preferably if you are using atorvastatin, you can try with 40 milligrams. If you are using rosuvastatin, yes, you can use 20 milligram. So if you don't get the desired amount of LDL reduction, then you add the ezetimibe, even for the primary prevention. Even for the primary prevention, you can go up with PCSK9 inhibitor if you have facilities to get it done. We have a few patients, actually, we got them down, and we have given those patients PCSK, the patient with primary prevention, even for the very high specialties, familiar high risk group. The secondary prevention also same. So you have to start the very high tolerable dose, the highest tolerable dose, then add the second drug or then third drug depending on the patient's response. So sometimes your patients are intolerant to statins. So what you can do in those situations, you can change the drug. Sometimes in our practice, sometimes the patient is not tolerant to rosuvastatin, we might change to atorvastatin. So they will be better off with atorvastatin. Sometimes in rare cases, we again go back to simvastatin. So those patients also will do better with simvastatin than atorvastatin or rosuvastatin, especially these muscle pain or increased CPK levels. So there are still you can use, and they are still in the guidelines. So again, so if you have facilities, then then you can even single hand, you can give PCSK inhibitor, even the patient is not tolerant to, if the patient is not tolerant to statins. So other methods also available. So then you can try. So this is actually the summary of pharmaco treatment. So when you assess the total risk, the baseline LDL level, then you decide this patient needs treatment. So if they don't need, okay, they are only for lifestyle modification. And if they need treatment, you start with the potent statin treatment. Then with that, you monitor the patient. Preferably, you can monitor after 6 to 8 weeks, as sometimes 4 weeks is enough. But after 2 months, basically, they will have a reasonable level. Then you continue. If they don't have reasonable control, then you have to add the ezetimibe. Still, if they're not under control in another 2 months' time, then you can consider these drugs or other drugs if they are available. So what are the other modalities of treatment available? So these ezetimibe, in addition to statins, ezetimibe is available, and icosapentalenol is also available, but we don't have bempedoic acid or we have hybrids. We can try if they're having a very high triglyceride levels, but the direct effects not there. And these monoclonal antibodies are not widely available here, as well as inclisiran. So these are not available in our setup yet. But if you have these actually validated, I will come to this later. And then if you have facilities, you can get them used. So everybody has a fear of lowering cholesterol. So is it safe to have low cholesterol? Yes. So all these guidelines and all these trials showed there's no definite evidence of increased risk of cancer in your patient if they have very low levels of LDL cholesterol. There's no increased risk of hemorrhagic stroke. There's no cardiovascular death or neurological dysfunction, even dementia. They say there's no reduction, the increased incidence of dementia when they have low levels of LDL. So you don't need to worry about that. So you achieve your target. So this is again the same slide. And so there's no evidence supporting adverse effects of these. So what happens most of the time when you see a patient in your practice, you start them on cholesterol lowering tablet. So after 2 months, most of the time they come to you with the lipid profile. What do? You discontinue the statins or you modify your statin dose. Yes. Okay. So depending on the results, you decide what to do. But you should not discontinue completely, because when you discontinue these statins, then they will be the more cardiovascular events. So that is proven in these 2 trials. So it is not to, it's better not to discontinue them, right? And also, when you want to, especially these categories, like this patient with acute coronary syndrome, especially these young patients. So you have to do this family screening. So because these patients have very high risk of coronary vascular or this, atherosclerosis plaque disease if you don't treat them. So these are familial hypercholesterolemia. They will have the coronary events even with their third decades. And so if you treat them, you can delay the onset of these complications. So it is vital to screen for these familial hyperlipidemic conditions if you have any doubt, especially patient who comes with young MI and the patient with very high family history, then you have to do the screening. And so if you treat them, you can definitely bring them their coronary events low by treatment. Okay, so now even whatever the says, there still this even the guidelines are there, and the practice is different. So even the Australia, the UK and USA, they showed all these patients with MI at the end of 1 year, only 35% had been on higher doses of statins. 45% of had a moderate doses, and 5% had a very low doses, like 2.5 every day, 5 milligram once a week, like that. So still it is challenging. So and in our practice also, we see most of the patients are discharged and after acute coronary events. So I can't even find this statin in these prescriptions. So they come without prescription, without statins. So it is very essential to make sure they are discharged on statins and all other medicines as well. So why these gap there? Because these are because of the patient's related factors, healthcare related issues, and sometimes physician related factors. So the patient related, most of the time they feel some side effects, basically muscle symptoms and increased levels of transaminases. And the patients also will have a fear of having diabetes, especially with these rosuvastatin. So they ask doctor, if I am getting this tablet, will I get diabetes? So they will have fear. So that's the reason they are afraid to take the normal doses or desired doses. And so other thing is the clinical inertia. So it is because even the guidelines set the targets, still the patients as well as the physician have inertia to give the proper or complete doses. And I will talk about special conditions like dyslipidemia in Asians and the Sri Lankans. So the different from these in the world is we have very low HDL levels, and the triglyceride levels are high, and also moderate LDL levels. And if you consider this elevated non-HDL cholesterol levels are also observed. And LDL particles, especially these ApoB and the LPA levels are relatively high in Asia, especially South Asians and Sri Lankans. I don't know, in your practice, do you check LPA levels? How many of you check? Yeah. Selected cases. Yeah, we also do selected cases. So if I have time, I will actually discuss when to check for these patients. So special situation like diabetes, because of the time restriction, I'm not going to talk much. So these patients also will have, depending on their clinical features, they will have targets, different setup of targets. And so this is again special. And in our practice, we believe that atorvastatin, the optimal dose as well as the rosuvastatin, the higher dose, optimal dose, maximum dose will give the same effect. But recent published this trial showed diabetic patients, they will have better LDL reduction with rosuvastatin than atorvastatin. And this was published in American Journal. Okay. So again, patient with acute coronary syndrome, I discussed earlier the target values. I'm not going to talk again. And this is again the patient with chronic kidney disease, and also they will have these different targets. And if I talk about this triglyceride, the triglyceride also a separate group of cholesterol. They will the increase triglyceride if it's more than 150, then they will have moderate to high rate increase is associated with significant increased risk of all-cause mortality in these patients. So it is vital to treat those triglyceride as well. So triglyceride is there are several trials which are done in Europe, and that shows this eicosapentaethate decreases cardiovascular death after MI in those patients who were treated with eicosapent. And this is the trial which showed that evidence. And these patients will have their different target values. So other category, actually, this was not discussed much in previous era. And this is actually this Bob Harper. He was actually CNN activist, I would say. So he was the TV programmer. He was very concerned about the health and the sports. So this he was doing all his TV programs, but he had a MI at age of 45 or something, young age. So then people have looked into that. It was basically LPA associated, and so then there was a big theme, because even the people who are going for these athletics and the health conscious people will get heart attacks and dying. So that's why this came, and then the ultimately it was found that his initial LPA level was high, but it was not attended properly by the GP during his previous visit. So that's why this chart shows LPA, very high LPA levels will have very high rate of coronary events. So LPA assessment is available, and if you have doubts, and especially when you can't get down your patient's LDL level with the highest dose, whatever the available drugs, then you suspect this condition and check the LPA. And which is costly now, it costs around 9,000, but you don't need to do it repeatedly. If you do it once, then you can diagnose it. So once you diagnose it, what do you do? Is a genetically determined diet and lifestyle have no effect on this LPA. So if you run 10 kilometers, there's no excuse. So you have to treat. Okay, so treatment, yes. And there are drugs, and statins has some effect, but there's no much effect on that. Estrogen replacement showed, and niacin, which is available here, you can try with niacin or nicotinamide. So that will reduce by 30 to 40% baseline level, and that will give some evidence. And also the PCSK inhibitors also reduce only by 25%. So other than that, the newer drugs as insulin, so that will actually reduce this LPA cholesterol, but it is still in the clinical trials now. So, ladies and gentlemen, so now we have come to the final slides of this presentation. So as I was talking to you about this 20 minutes, the LDL is the main cause of atherosclerosis. So regression of atherosclerotic plaque is possible with adequate lipid lowering. LDL level increases with age, and there are guidelines. They have definite treatment goals for all categories of patients. Risk scoring system will help you to risk stratify your patients and avoid unnecessary interventions. And despite all treatment options, achieving target in some patients is challenging because of multiple reasons. Okay, thank you very much. So